Good evening, all the respected dignitaries and academicians. It is 1st June and Maha IIP with Raigad IIP is here with you with pure academics. We present to you common clinical problems and studies which enrich us in day-to-day clinical judgment while practicing in a resource-limited setting. Half of 2024 is past and we are heading to rainy season. Infections, food and waterborne diseases will be on the rise, and for discussion, we have chosen the appropriate topic of hepatitis. In this journey, I am happy to invite Raigad IIP editor and important pillar of digital platform, young and talented Dr. Neha Singh, to introduce both the experts as well as speakers and welcome all the guests. Over to Dr. Neha.
Thank you so much, Chitra ma'am, for the lovely intro. Good evening, everyone. Myself, Dr. Neha Singh, and on behalf of Maharashtra IIP and Raigad IIP, I welcome all the respected dignitaries, seniors, and colleagues for today's journey. I welcome Maha IIP President Dr. Ram Gopal Chezara sir, Secretary General Dr. Amol Pawar sir, as well as the respected executive board members of Central IIP and Maha IIP. I also welcome Raigad IIP President Dr. Vikas Kore sir, Secretary Dr. Ajay Kohli sir, our patron respected Dr. Niman Mohanty sir, Jay Bhandarkar sir, Chitra Kulkarni ma'am, and all the members from Raigad IIP and other branches. Today's session has been granted 1 MMC point, so requesting everyone to please type your name, MMC number, Central IIP number, and city in the chat box. Dr. Prashant Badane, pediatric cardiologist practicing at Nasik, is our MMC observer. We welcome you, Prashant sir. Our today's session, we have two experts with us, Dr. Niman Mohanty sir, Professor Emeritus Pediatrics at MGM Institute Health Sciences. He is also member of Academic Council and Advisory MGM. Sir was former DIG Medical and Chief Consultant Pediatrics at CP MFMS, recipient of Meritorious Service Medal from President of India. He has over 500 presentations, 65 publications, and authored 3 book chapters. We also have with us Dr. Bhavna Lakhar ma'am as expert. Ma'am is Professor Emeritus JNMC Wardha, Consultant Pediatrician at New Era Mother and Child Hospital, Nagpur. Ma'am has 36 years of teaching experience as teacher, a PG teacher and PhD guide. She has more than 100 publications and presentations. Her special experience and interest are in lactation management and human milk bank. While our presenters for today are Dr. Nirav Patel, MBBS, DCH, DNB Pediatrics, Fellow in Pediatric Critical Care. At present, he is consulted pediatric intensivist and neonatologist at Nagpur. He is presenting the review article, Hepatitis C, the current status of treatment in children. Our second presenter is Dr. Prashali Vada, MBBS DCH, at present NICU consultant at Medicover Hospital, Kharghar. She has been presenting the research paper, Direct Breastfeeding Frequency of Late Preterm and Term Infants in NICU and Availability of Mother's Own Milk at 6 months of age. So now I request and hand over to Dr. Nirav Patel. Sir, you can share your slides and start the presentation.
Perfect.
Good evening, respected dignitaries, seniors, and colleagues. I'm going to present this review article on hepatitis C, the current status of treatment in children. So this article was published in 2021, and it is by Sanu R. Yadav, Deborah Goldman, and Karen Murray. So to begin with, in 2015, WHO estimated 5 million children with chronic hepatitis C worldwide. Despite slow progression, the possibility of long-term liver disease like cirrhosis and hepatocellular carcinoma is there in children. So the characterization of HCV genome, which led the winning of the Nobel Prize in 2020, this leads to the development of directly acting antiviral drugs that can cure most chronic form of the hepatitis C. So the focus of this decade has shifted to ensuring the availability of DAs to millions of people worldwide. And WHO's now goal is to eliminate hepatitis C virus by 2020, specifically 90% reduction in chronic HCV infection and 65% reduction in mortality associated with HCV infection. So virology, hepatitis C virus is single-stranded RNA virus. It has two type of protein, which is E1, E2 is envelope protein, which helps in attachment of the virus. And the other one are the structural and non-structural proteins. There are 3 structural proteins, namely core E1 and E2, and there are 7 non-structural proteins. This protein plays important role in replication of the virus, and they undergo rapid mutations, more than 100 mutations per day. So it is very difficult to develop a vaccine of hepatitis C virus. This is structural proteins, non-structural proteins. Now, natural history of hepatitis C virus infection. So the transmission is mainly parental. Most common route of transmission in pediatric patient is perinatal. It accounts for almost 60% of total transmission in pediatric age group. Second is first is vertical transmission, not parental. I'm sorry, vertical transmission accounts for the 60% of the transmission. Second route is parental route, like intravenous drug uses or intranasal drugs. In the era of opioid pandemic, it is one of the most important route of transmission in adolescents and adult. High-risk sexual practice is another route. In children, vertical transmission is most common. Now, this 75% of acute infections, which is acquired outside the perinatal period, will this 75% of infection will develop into chronic viral infection. And infection that are acquired in perinatal infection, 25 to 40% of this infection clears spontaneously by 2 years of age, and another 10% will clear by early childhood. So this natural history, hepatitis C virus infection has very indolent infection with minimal or no symptoms. 80% of the child will have no symptom. They just have HCV virus or some unexplained rise in liver enzymes. Symptomatic HCV infection is very rare, and when symptoms are present, they are like fever, malaise, viral prodrome-like. It is very rare. It very rarely causes acute liver failure. In those who fails to clear the virus, fluctuating levels of serum aminotransferase are typical, and over decades, it can result in liver disease with a risk of cirrhosis approximately 20% after 20 years. Screening and diagnosis of HCV infection. So rising prevalence and silent transmission. Because of this, identification of chronic HCV infection is very important. And it is possible through the universal screening strategies, which includes, like, when you see a child with unexplained chronic elevation of liver enzyme, which is not explained by anything else, you should suspect the HCV infection. Those receiving frequent blood transfusions, like patient having thalassemia or sickle cell anemia, or those who have leukemias, or those who are treated and completed the treatment of leukemias, but now having some unexplained chronic elevation of the liver enzymes, you can suspect HCV infection. History of intravenous drug use or intranasal drug use. This child should also be screened. High-risk sexual practices. The child with HBV infection or HIV infection should be screened for HCV infection, because if the child is having HBV infection and HCV infection, so when you start treatment for the HCV infection, it can result in the fulminant infection by HBV. It can reactivate the HBV infection. So whenever you find child with HBV infection or HIV infection, you should screen for HCV infection. Child on hemodialysis, you should screen for HCV infection. Those child in correctional facilities or homeless environment, international adoptees, child having tattoos from unregulated places. These are the high-risk childs who must be screened for the HCV infection. US Preventive Cervix Task Force recommends universal one-time HCV screening, that is by anti-HCV antibody testing for all adults, including the pregnant women. Methods of screening, according to American Association of Pediatrics, American Academy of Pediatrics, anti-HCV antibodies screening should be done at 18 months of age and confirmation of a positive child with PCR test after 3 years of the age. Infection AASLD recommends HCV RNA detection by PCR by quantitative method during first year of life. Optimal time is not known, earliest is 2 months. Children or adolescents confirmed to have HCV infection with quantitative HCV RNA by PCR should be further evaluated for the serum aminotransferases, GTT, fractionated bilirubin, albumin, PTINR, alpha fetoprotein, CBC, and liver spin USG. So treatment. After the invention of directly acting antiviral agents, the treatment has seen the paradigm shift, because previously the ribavirin and pegylated interferons were the only mainstay for the treatment that required 24 to 48 weeks of the therapy and subcutaneous administration. DDAs are now considered standard of care for chronic HCV infection. They have targets for direct viral interference. DAAs have advantages like oral administration, better tolerance, better viral clearance, and they have minimal side effects. So basically, there are 3 categories of directly acting antiviral agents. The first category acts on non-structural proteins NS3 and NS4A. They are known as previrs. They interfere with HCV protein cleavages, and the category includes boceprevir, telaprevir, gelaprevir, cimeprevir, grazoprevir, and voxlaprevir. The second category acts against NS5A protein, and they are known as ASFIRs. They prevent formation of membranous web and virion, and this category includes ledipsavir, pibrenstavir, declastavir, umbritasvir, velpatasvir, and elbasvir. Third category includes acts against NS5B protein, and they are known as buvirs. They act against NS5B polymerase. They are basically NS5B polymerase inhibitor, and it includes sofosbuvir and desabuvir. So current treatment is the combination regime. So these are the regimes which are used in pediatric population. This HCV virus has 6 genotypes. So based on the genotype, the regime is usually preferred. The first regime is ledipsavir and sofosbuvir. The duration of the therapy is 12 weeks. It is useful against genotype 1, 4, 5, and 6, and US FDA approved for the age of 13 to 11 years in 2019. Previously, it was used to treat HCV infection for 12 to 17 years of age. Now it has upgraded to 3 to 11 years. Once daily dose of this fixed drugs combination for less than 17 kg, 33.75 milligram of ledipsavir and 150 milligram of sofosbuvir. 17 to less than 35 kilogram, 45 milligram and 200 milligram combination is there, and more than equal to 35 kg, 90 milligram and 400 milligram combination is used. The second drug regime is sofosbuvir and ribavirin. Duration of therapy is 12 weeks, and it is active against genotype 2 and 3. FDA approved for the use for 3 to 17 years of age. it is not a fixed drugs combination. Sofosbuvir is used in dose of 150 milligram for less than 17 kg. From 17 kg to less than 35 kg, the dose is 200 milligram, and for more than equal to 35 kg, dose is 400 milligram. Ribavirin less than 47 kg, 15 milligram per kg. For 47 to 49 kg, 600 milligram. 50 to 65 kg, 800 milligram. 66 to 80 kg, 1000 milligram. And more than 80 kg, 1200 milligram. Gleclaprevir and pibrenstavir. It is pan-genotypic. It can be used for any genotype from 1 to 6. Duration of therapy is 8 weeks. It is approved for the treatment of child age 6 to 17 years, and trials are ongoing for the use in children of age 3 to 6 years. Once daily dose of fixed drugs combination, more than 12 years, the dose is 300 milligram and 120 milligram. The fourth one is sofosbuvir and velpastavir. It is also pan-genotypic. Duration is 12 weeks. It is approved for the age 6 to 17 year into 2020, but now it is approved for use from the age 3 years to 17 years. Sofosbuvir and velpastavir less than 17 kg, 150 milligram and 37.5 milligram. Between 17 to less than 30 kg, 200 milligram and 50 milligram of fixed dose combination, and more than 30 kilogram, 400 milligram and 100 milligram combination. There are other regimes which are under trial. Ma'am, the screen is not moving. Yeah. So all children at high risk should be tested for the HPV infection, and all the trials have reported minimal or very like less side effects in all the children. The most common side effects are headache, flu-like symptom, vomiting, nausea. Any of the trials have not reported any serious side effects with the directly acting antiviral agents. So what this study adds, all children at high risk should be screened for HCV. If you suspect any child in your practice with fluctuating serum aminotransferases level, and especially if that child belongs to the high risk group, such as a child with IV drug use or intranasal drug use, or on receiving chronic blood transfusion therapies like thalassemia or leukemias or sickle cell anemias, those childs should be screened for HCV infection using anti-HCV antibodies. And if it is positive, it should be confirmed by HCV PCR at HCV RNA PCR. Infant born to HCV positive mother should be screened after 18 months for HCV anti-HCV antibodies. And all children more than 3 years with HCV infection should receive treatment with directly acting antiviral agents. Early treatment is very effective. It helps in preventing the long-term complication like chronic liver disease, cirrhosis, or hepatocellular carcinoma. It also reduces the cost of therapy. If you begin your HCV therapy early, it will be less economical burden to the family. And screening of HBV infection should be routinely done before initiation of directly acting antiviral therapy, because after initiation of DEA therapies, if do not screen the child for HBV infection, it can reactivate the HBV infection, which can sometimes cause fulminant hepatitis. And second thing, those children with HCV, indolent HCV infection, may have a severe form of hepatitis A virus infection. So all these child who are suspected to be HCV positive should be vaccinated against hepatitis A virus and hepatitis B virus. I'm sorry, I'm not able to move my slides. So challenges and the future direction. With the advancement and invention of the DAA, it has.
Sir,
it is.
Sorry
Yes.
to interrupt, Dr. Nirav. You can stop share and you can reshare again and try.
Okay.
Because the further slides are more important. It's a very good presentation. We appreciate.
Thank you, ma'am. Yes.
Yeah, make it full screen, please.
So these are the common side effects like headache, nausea, fatigue, diarrhea, drug-related fever, and URIs. No serious adverse effects. And cases of reactivation of HBV, as I said, in patient with HCV or HBV co-infection have been associated with HBV clearance when targeted DA therapies are introduced. So all children at high risk must be screened. Positive should be confirmed with HCV RNA by PCR. Infant born to HCV positive mother should be tested at or after 18 months of anti-HCV antibodies. Early HCV RNA PCR as early as 2 months of age can be done. All children more than equal to 3 years with HCV infection should receive treatment with directly acting antiviral agents. Early treatment is cost effective and reduces lifetime risk of complications like cirrhosis and hepatocellular carcinoma. Children with chronic HCV should receive vaccine against HIV and HBV. Screening of chronic HBV infection should be routinely done before initiating targeted DAA therapy. And challenges and future directions. The advancement in newer, safer, and broad DAAs has not translated into improved access and utilization in pediatric population. So this is the biggest public health challenge, to provide the DAA to the needy population and identifying the child having indolent infection by routinely implicating the screening of HCV infection. Children often have minor symptoms and usually do not develop serious disease or complications, whereas DAA therapies are restricted to advanced disease by many insurance providers. So this thing has to be changed. DAA therapies should be started early after the diagnosis. The age of the child should be more than equal to 3 years, because many of the child clears this infection before the age of 3 years. That's why the timing of beginning of the DA therapies is equal to or more than 3 years. So once you diagnose the disease, you have to start therapy after 3 years. It needs to be emphasized that providing timely treatment to children who do not clear the virus spontaneously will be crucial in reducing long-term burden of chronic disease as well in global elimination of HCV. Universal screening at population level is still lacking, especially in child with perinatal exposure and high-risk adolescent. This it should be implicated in public health, like routine screening of HCV infection. Identification of children who are infected and linking them to accessible care system will require strong public health strategy. Thank you.
Thank you, Dr. Nirav. It was an excellent presentation. May I invite our expert for this hepatitis C topic is none other than our mentor, an academician par excellence, Dr. Niman Mohanty, sir.
Thank you, Dr. Chitra. Welcome, friends. So the whole purpose was to keep this topic was to sensitize our pediatricians about the existence of such a disease or such a infection which can result into chronicity and cirrhosis of liver and also to hepatocellular carcinoma. In our student days, let's say PG days also, thesis was given for chronic liver disease, where we are getting cirrhosis called cryptogenic cirrhosis. That means we're not able to find the etiologic agent of that cirrhosis. All the hepatitis B was assigned, hepatitis D was assigned, other viruses were assigned, but nothing like this hepatitis C was there. So it was called, you were presuming that it was probably because of a virus. We call that time is neither A nor B.
Non-A, non-B.
Non-B.
Yes.
Now, subsequently, it was designated as hepatitis C. It's neither A nor B, the hepatitis C. So, hepatitis C is also equally dangerous. Like it also through the vertical transmission also comes, mother to child. See the irony, if our system policy is there, policy planners should take note that when there is a grant from abroad, like HIV/AIDS, we got a lot of grant. On that grant, we had so many projects and so many drugs, treatment schedules allocated to that grant base. Only 0.0000 ml blood from hepatitis B can infect a baby. That is not assigned to directed towards hepatitis B, which is also playing a major chunk of the disease, chronic liver disease in India. We are not bothered because HIV, we are getting funding, so we are concentrating on that on. So subsequently, hepatitis B vaccination came for children also, neonates also started doing it. And we wanted to know the hepatitis B mother status at the time of birth. So then some projects were also having the cord blood status, and according to the presence of hepatitis B in mothers, hepatitis E particularly, antigen E in mother's blood. So this active immunization also started in babies. But C is neglected. So because we don't have a vaccine, that doesn't mean we should ignore C. C is also equally dangerous. We should also screen our mothers, which we are doing in the blood banks also. All the blood screening is happening. But here, every mother should be screened of hepatitis C also like hepatitis B. And those found positive, that particularly the cord blood.
Okay, Dr. Nirav, will you please stop sharing your screen?
Yes, ma'am.
Yeah, and I request Dr. Jay Bhandarkar for a few comments. Dr. Jay, are you there? Dr. Jay Bhandarkar, sir. Dr. Nimen Mohanty is in Bhubaneswar. Dr. Jay Bhandarkar, sir, your comments for hepatitis C.
Thank you, Nero, for the excellent presentation.
Thank you,
And
sir.
why it is important, right? So as you are always aware that even common infection, which is acute viral hepatitis A, which is very asymptomatic in even pediatric patients. Usually they present as a later age. Any all this viral hepatitis, they present later age, and so pediatricians always chance of they miss that diagnosis, right? So awareness about all hepatitis is important, and as well when you talk about the hepatitis, usually thought of this hepatitis B as vaccines available, hepatitis A, and other we forget. But there are other viruses also, and that is one of the important is the hepatitis C virus, right? Because suppose you get an early age infection, so it is always 75 to 90% chance you may remain a chronic state, and you go for hepatocellular carcinoma or cirrhosis. And fortunately, wonderful drugs are available, direct acting antivirals. And as I work in there are 6 types of genotypes, and this pan genotype acting antivirals available. This is very, very important in physical combination. Suppose you diagnose, yes, we are working, many patients get cured by 3-year age. So they require treatment after 3 years of age. So very nice presentation. I don't think so there is any questions I'm seeing in the chat box, right?
Yeah,
So
thank you.
excellent.
Dr.
And as Madam said, I have gone through many literature today afternoon, because Madam invited you as an expert for this. Suppose Niman Mohanty sir doesn't join as he is in the Bhubaneswar. So thanks
Thank
for
you,
that.
sir. Thank you.
I was
Thanks
an
for
alternative
fitting in.
second
Yes.
person for this today as an expert. Thank you very much.
Thank you, sir. Thank you very much. Thank you, Dr. Jay. So nice of you. And now we move on to the second presentation. I invite the presenter, Dr. Prashali Vada. She is working in NICU in Medicover Hospital, Kharghar. Over to Dr. Prashali. Please share your screen. And you may put your audio off if the bandwidth is very low. Okay. We want host to unmute Dr. Prashali. Yeah, please
Okay,
start.
okay, ma'am. Good evening, all the dignitaries and my colleagues. Myself, Dr. Prashali Pada. I am presenting the case.
You have joined through two devices. You will have to stop one.
Ma'am, please mute your second device.
Okay,
Prashali ma'am.
okay, ma'am. Okay, ma'am. Today I am discussing the case of direct breastfeeding frequency of late preterm and term infants in the neonatal intensive care unit and availability of the mother's own milk at 6 months of age. It is a retrospective cohort study done by Aman Smith in the Department of Neonatology, Cleveland Clinic Children's Hospital in the USA. The background of the study is mother's own milk (MOM) reduces the risk of complication in the premature infant. The breastfeeding rates for late preterm and term infants in the neonatal intensive care unit, that is in NICU, are significantly lower than that of breastfed healthy term newborns at 6 months of age. This study was retrospective cohort study. The American Academy of Pediatrics and the WHO recommends exclusive breastfeeding until 6 months of age for all newborns and continue breastfeeding for 2 months, 2 years of age and beyond. Now, the breast benefits of mother's own milk. As we know, mother's own milk is the best nutrition for infants in case of decreasing feeding intolerance, late onset sepsis, and sudden infant death syndrome. In premature infants who receive MOM have decreased risk of complication like necrotizing enterocolitis, neurocognitive delays, and retinopathy of prematurity and chronic lung diseases. The even partial breastfeeding has been shown to be beneficial to the children in terms of reducing infections, eczema, and asthma. Breast milk provide the best nutrition, immunity, metabolism, and growth and development for infants. Breast milk contains hormone, neuropeptide, and growth factors that are beneficial to growth, development, self-regulation of food intake in infants. Now we are discussing factor affecting exclusive breastfeeding. The immature feeding patterns of prematurity. There is a delayed initiation of direct breastfeeding. There is a higher stress level in the mother, a lack of bonding between the mother and the baby, low rates of skin to skin care, that is KMC, and prolonged hospitalization in case of mother and baby both. Now we move to the objective of the study. This study was to evaluate the relationship between the frequency of direct breastfeeding of late preterm or term infants while in the NICU and the availability of any amount of mother's own milk for the infant at 6 months of age after adjusting for the known confounding variables. The duration of 6 months was chosen as it is the minimum recommended length of time to receive breast milk. The study was the retrospective cohort study approved by the Institutional Review Board, that is IRB, of the Cleveland Clinic Foundation. The study was conducted in the level 3 neonatal intensive care units in the urban setting on admitted neonates who met the inclusion criteria between the January 2020 and April 2021. The participants are the infants born within the Cleveland Clinic hospital system requiring admission to the neonatal intensive care unit, that is in NICU, and fulfilling the following study criteria were included. Now we move ahead with the inclusion criteria. Infant born at 34 weeks days or later discharged from the NICU and had a followed up within the same health system. Mother initiated breastfeeding in the NICU. Infant receiving human milk at discharge. Exclusion criteria are infant with NICU stay for less than 5 days, medical contraindication to the breastfeed, that is HIV condition, the anti-conversion drugs, and the anti-cancer drugs, mother not providing breast milk at discharge, the more than one readmission or more than 2 emergency department visits by the infant in the first 6 months of life, multiple live births, and diets without information about breast milk feeding at 6 months. Now we move ahead with the data source and measurements. First is mother age, gravida, the days on respiratory support, vaginal delivery type included forceps, either forceps or vacuum deliveries, the number of lactation consultations, number of direct feeding attempts during the NICU stay. This is the outcome we found from the study. The ABCA score at 5 minutes, vaginal delivery, age of mother, lactation encounters, and number of next. This is again the analysis. Here we can see the number of time breastfed in the NICU have more significance compared to the rest of the parameters. Further, we discuss the result in details. It's a total 184 infants mother diets were included. Among the 171 infant included in the final analysis, 13 are excluded. The median gestational age at birth was 35 weeks with a birth weight of 2370 grams. The at 2 months, the number of infant getting MOM was 96 out of 170. That is almost 56% at 2 months. Then which decreased to 69 out of 171 at that is up to 40% at 4 months, and it further decreased to 57 out of 171 mother and infant diets at 6 months of age. The median length of stay was 10 days, maternal age was 31 years, the infant on respiratory support was less than 1 day, and median number of lactation consultant visits were 7.5. The infant receiving MOM at 6 months had a higher birth weight and gestational age, but the difference was not significant. That is 2452 grams versus 2332 grams. The ABGA score at 1 minute, same in terms of group that received MOM at 6 months, but only 5 minute ABGA was significantly higher in the group that received MOM at 6 months. The mothers of the infant receiving MOM were significantly older than those receiving MOM. That is, we can see 33 versus 30 years. The significantly higher number of infants who received mother's own milk at 6 months were born by vaginal delivery. It is 51% versus 33%. That is, who are not getting mother's own milk at 6 months. The infant in the group who continued to receive mother's own milk at 6 months had more bell babies, that is up to 68%, and mother with low rates of smoking during the pregnancy. The number of LC visits were significantly higher in the group that received mother's own milk at 6 months. The number of breastfeeding attempts during the NICU stay were significantly associated with the infant availability of mother's own milk to the infant at 6 months of age. That is, we can see 7 versus 21. There was no significant difference between the group in terms of length of stay in the NICU, gravity and priority of the mother, infant's number of days spent on the respiratory support, either on the CPAP or the ventilatory support. There was 9.5% increase in odds of the infant getting mother's own milk at 6 months if the infant is directly breastfed in the NICU when adjusted for the confounding variables. Now, the conclusion of the study. The study states the importance of direct breastfeeding in the NICU for late preterm and the term infants. The increased number of direct breastfeeding attempts in the NICU is associated with the higher rate of any amount of mother's own milk feeding at 6 months age of the infant. The study showed that the need for supplementation and bottle feeding of late preterm infants should be finally balanced with encouragement of the direct breastfeeding. Prospective studies are needed to confirm the finding of the study and identify strategies to support mothers who face challenges in the breastfeeding while their infant is in the NICU. Limitations of the study. The amount of breast milk available to the infant at 6 months was not quantified. Study did not consider the breast milk feeding rates at 1 to 2 years of age. Retrospective studies have inherent bias which is difficult to determine and eliminate. While skin-to-skin care is recommended and encouragement to the correct direct breastfeeding is data is not available with us. Breastfeeding support outside of this Cleveland clinic system, such as through lactation consultant, pediatricians, clinics, or support groups were not examined during this study. And COVID-19 may have affected breastfeeding in the NICU because the study done during the COVID period. Now we move ahead with the IIP guidelines. As we know, there is a IIP recommends exclusive breastfeeding for 4 to 6 months, followed by the gradual introduction of semi-solid and solid foods to supplement breast milk. The take-home message to the all pediatrician and the healthcare workers, that is early initiation of the direct breastfeeding is important in terms of both preterm and the term infants. Early initiation of the breastfeeding, that is the baby should receive the first breastfeed as soon as possible, that is during the delivery room, in the delivery room, and preferably within the half an hour of the birth. Value of colostrum, as we know, colostrum is basically the first immunization a child receives from the mother. These are infant hunger clues that we are aware of. If baby is staring, mouth opening and turning head, these are the signs that baby is hungry. Baby is really hungry. Baby can show the stretching, physical movement, hand to mouth. Then if baby is hungry, baby becomes upset. If baby is not getting the feed, it shows crying, agitation, and turning. Baby can turn red. These are different position of the breastfeeding. That is a cross cradle position, sideline position, and inverted slide position. And one more, there is a football method, and the twin babies we can use football method to feed both the babies. So thank you all, and special thank to Chitra Kulkarni ma'am for giving me the opportunity to present this case, and Bhavna ma'am to guide on this presentation, and Mohanty sir to highlight the slide. Thank you.
Thank you. Thank you. Please stop share. Now, may I invite Dr. Bhavna Lakkar ma'am, a hardcore teaching career, for her expert comments. Dr. Bhavna, please. Bhavna Lakkar madam had joined. Ma'am, are you there?
Good evening.
Thank you, ma'am.
And thank you, Chitra madam, for saying nice words. So this is a retrospective study where they have tried to find the factors affecting continuation of breastfeeding to 6 months. And of many factors, they have found that direct breastfeeding is the one. The frequency, mainly they have found the frequency. They have not assessed the quantity of the milk, but the frequency. But basically what we know is the emptying of the breast. Emptying of breast, if it is more, there is a better establishment of lactation and continuation of breastfeeding. That part has not been taken into account in this study. But in one place they have mentioned that those mothers who have given direct breastfeeding have done better than the mothers where only milk was expressed. But there is no data available. But we agree that this is a fact. So how this has happened that direct breastfeeding is important? more than the expression. So two things are there. One is the emotional bond between the mother and the baby, and second is skin to skin contact. So they have also quoted, the authors themselves have quoted one study where the first oral feed was given as a breast milk. And there also they have found that large number of babies were at 6 months on breastfeeding. Then I also found one study done in Vietnam, published in 22, where they have taken into account not only the direct feeding, KMC, duration and the frequency, and also the counseling of mother during antenatal. And they have found that 66% of these mothers continued the breast milk at 6 months also. In this present study where they have taken only direct breastfeeding, they have found only 30% babies who are on the breastfeeding at 6 months. So this difference may be because it is also one retrospective study, and whereas the other one is a prospective study where the conditions are very controlled. Most NICUs, they focus upon the weight gain in the baby, and hence direct breastfeeding is usually delayed because we think that when baby is suckling, the calories will be utilized, and hence it is usually delayed, and calorie supplementation we more focus more on that. So maybe this study says that both are important, and we have to supplement some extra calories, but continue with the direct breastfeeding. That is one of the things which comes out of this study. But I think more prospective, as it is known that retrospective study has a bias. Then two things which I have already shown is the emotional stress which mother has when baby is admitted. And second thing is lack of skin to skin contact, because in this study, COVID also was there. Plus, when baby is sick, many places mothers are not many times allowed. Only some duration is there when mothers can go. These factors must have come. Other factors which they have studied is the age of mother, Apgar at 5 minutes, visit of the lactation consultant, and the type of delivery. They were significant, but during multiple regression, they were out, and only the direct breastfeeding became very, very important. They also made one ROC curve, and they found that at 6 months, this availability of MOM at 6 months of life was a binary outcome variable and shows a very good discriminative ability. So that again shows that it is a very good factor, and area under the curve was 0.76, where usually it is more than 0.5 is very significant. So this looks like that it is a very significant factor. Then birth weight of babies, as was shown in the presentation, then the Apgar at 1 minute, and days spent on the respiratory support. They were very near to significance, but they were not more than 0.05, so were not significant. But if a prospective study is done, maybe even those factors might come to in the value. So these are my comments. But two things from my side. One is in the Indian situation. Two more things are important, that the counseling when it is done, like lactation consultant counseling the mother, we should also counsel the grandmother and the husbands, because mother usually takes the support of the family. And if the family support is there, it is more chance that mother breastfeeding will be continued till 6 months. Second thing is the maternal education also is important. Most of the educated mothers, they know that they should continue the breast milk for a longer time. So these are my observations in this study. So I think that is from my side. Thank you.
Yeah, thank you. Thank you very much, Dr. Bhavna ma'am. And it was a elaborative description about the paper, and the shortcomings also, they were told in a very good way. Now we move on to the next part. We want to know about the questions from the chat box. Pallavi ma'am, are there any questions on YouTube?
No, ma'am. No.
Okay. We request Dr. Jay Bhandarkar. Any questions on the chat box? Dr. Jay, you want to ask? Yeah, okay. I'm having few questions, ma'am. First is in our hospitals, lactational consultant concept is yet to come. So what is the solution for a mid-level hospital or privately run setups?
Nowadays, what we are doing is that most of the hospitals, they are training their nurses. Like in this present study also, they also train the nurses. So we take, whether it is a small hospital or big hospital, like myself, I have conducted so many like education program for the nurses, where we teach the nurses and they are the one who are interacting with the mothers. So during their own rounds in the morning, they can counsel the mother as well as the grandmothers and husbands for the lactation. And wherever milk banks are there, we have also in our institution, what we did is we get lot of rural mothers who do not have any approach to hospitals. They don't know about many things about the NICU and about the human milk bank. So we have made one recorded message, which every 2 hours, 3 hours it is announced. Okay, this is a very good thing to continue with the breast milk. These are the advantages. So this goes on playing in the ward. So at least when somebody visits, they also hear. Not only the mother has to hear at least 10 times a day, but the visitors also are listening. So that I found was a very good thing. And when they come, if you have human milk bank, when they come, anyway, we are counseling. Then in the human milk bank, we have special trainers also. Like we keep 2 or 3 trainers who go to the ward and then train nurses as well as mothers. So this is an ongoing in-service program which we have made.
Yeah, another important factor is 6 months is the age where the maternity leave is exhausted. There is no concept of getting a paternity leave in our country, but even the mothers are forced to join around 6 months when the baby is 6 months. And that is the crucial period. In this paper also, it was shown that it is nearing 60% only ladies who were continuing the breastfeeding. Am I
30%.
correct, Dr. Prashali?
30%.
30% only. So any solution like what you have said for audio message, any solution for this, ma'am?
One solution we are already trying, that all the wherever the mothers are working should agree for the 6 months. But then when they are joining at 6 months, usually we ask the working places, we are asking working places to keep a feeding area or milk expressing area. So the milk is expressed and somebody carries the milk to the house. And we train somebody what kind of box he can bring, like a steel box which is sterilized. Mother expresses the milk and give. So at least 3 times a day we are trying. That one study we did where the nurses in our hospital, where their babies are in their own houses, the 3 times a person used to come and take the milk. So this is how we can do it. Like that is one of the ways. If a house is nearby, then maybe we have to explain to the owner of that person, the boss of that office, to give some holidays. Holiday in the sense 1 hour, if lunch hour is 1 hour, give 1.5 hours to that lady. Same like this till 1 year of age. So these are the methods we are trying. Like in Manipal, for the postgraduates, we did it. If you have a baby during that period, then we used to give them long lunch hour. And then long evening hours, 1 hour extra, where they can go and feed the baby. In the night hours also, we used to call another postgraduate to replace this officially, not that in between, officially. She has to be like, it was put as a duty that they will come and they will replace the person and that lady can go and feed the baby. So these are the things which we can try.
Yes, very good initiative, and a person in authority should note it down.
Yes.
Our question for hepatitis, Dr. Nirav, you can answer. Are you present?
Yes, ma'am, I'm there.
Yeah. So the mother is hepatitis C positive. She was accidentally detected at around her 40 years of age, and 3 children are negative. So how to go about, how to prevent the transmission?
Okay. So my mother is 40 years of age. That mother screening should be done, and it should be confirmed by this PCR quantitative. And if she is positive, immediately the direct acting antiviral should be initiated with routine investigations like LFT, ultrasonography of the abdomen to see the status of liver, etc. And this children should be must be vaccinated against hepatitis A and hepatitis B during the routine immunization. And secondly, the screening of this child should be done, and this child should be regularly followed, and mother should be taught to prevent the accidental transmission, like some cuts or wounds that should be taken care of, which should not get transmitted, or some needles or some pins should not be, like it should not get transmitted to the child by accidental mode, any prick injury or anything by blood.
Yeah. Okay,
Yes.
thank you. That was
Yes.
the main point. Now I request Dr. Neha Singh. Any questions on chat box? Dr. Neha, I could spot her.
There is one question from Dr. Anil. For hepatitis C, what is the criteria to stop treatment once treated if the person still continues?
Yeah, Dr. Nirav. What is the criteria to stop the treatment?
Sir, we have to follow the RNA PCRs, like we have to simultaneously see the viral load, and there is a certain time, like every regime, there are 4 different regimes for the this HCV infection. Each regimens have different like time duration. So depending on the genotype, if you go for the Pine genotypic regime, it also take 12 weeks of therapy. So it should be continued for that period, and the viral load is to be monitored. So if the viral load is concomitantly decreasing, that person is become less infective.
Unless like hepatitis B, where we can only control.
Yes, yes.
Yeah. Any other question, Dr. Neha?
No, ma'am. There is no question any on YouTube or Zoom.
Okay, now it is already, the time is up. We are coming to the successful completion of this journal journey. May I request Dr. Jay Bhandarkar to give vote of thanks? Dr. Neha, will you please do the honors?
Yes, ma'am. Sure, ma'am.
Please.
So on behalf of Maha IP and Raigad IP, I thank all the respected dignitaries and seniors and colleagues for joining us today. I thank both our experts, Dr. Niman Mohanty sir and Dr. Bhavna ma'am, to accept our invitation for being the expert for today's journal journey session. They have given their expertise comments, which were very useful and up to date. I also thank both the presenters of today, Dr. Neerav Patel and Dr. Prashali, who have done their presentation very wonderfully. And I thank Maha IP President, Dr. Ramgopal Chezara sir, Secretary General Dr. Amol Pawar sir, then IP Raigad President Dr. Vikas More sir, Ajay Kohli sir, and all the esteemed executive board members of Central IP, Maha IP, and other branches for joining us today. I thank Dr. Chitra Kulkarni ma'am for doing excellent coordination for journal journey session. I thank Jay Bhandarkar sir for giving his expertise comments. I also thank Pallavi ma'am for giving the backup, and last I thank all the attendees on Zoom and YouTube Live for joining us today. Our next session will be on 1st of July, that is Doctor's Day, and please join everyone.
And we thank Dr. Neha Singh for helping us as always, for welcoming as well as the closing comments. The next episode of 1st July, 2 of the presenters have joined. Dr. Avanti, are you there here? You can just say hi. And Dr. Sadanand from Navi Mumbai. Dr. Avanti is from Nasik. Let us continue our journey for pure academics in next month also. And we thank all the dignitaries and the delegates who have joined. Pallavi ma'am, please stop recording now.
We also thank MMU